Definitely.
All right, my guest now, Dr. Jimmy Opigo is Program Manager, Malaria Control Program, Ministry of Health, and Dr. Janet Ola, she's District Health Officer, Nwoya District. Good morning, doctors.
Good morning.
Good morning, Joel, and good morning, viewers.
I'm sure you're very good doctors. Of late, we have been hearing many skirmishes about certain doctors in this country. That's for another day. Tell me, you're telling me that on an annual basis, 53,000 people die of malaria in this country, and there are 40 to 60 million cases of malaria, some inclusive of reinfections. One person can get severally infected every year. That's stupendous a number. What's causing this? What are we getting wrong, Dr. Opiga?
It's actually one of the biggest problems. The number you are referring to is after we have done so much work and actually half the deaths. Initially, we used to lose 300 people per day. Now we are talking of 150. That's one person per district. Because malaria kills very fast. It's very easy to transmit, but also it's very easy to prevent and cure if the actions are taken. It's a very old disease, has been known a long time ago. Some parts of the world have actually managed to eradicate it, and that is where we intend to move as Uganda, and that is what the World Malaria Day is about. You must have seen the theme is talking about end malaria for good.
Is that for the world generally or just Uganda?
That's for the world.
Okay. But we have our own here as well?
Our own, we decided to say to actually actualize that vision. We need to prevent, test, treat, and track.
All right. You people are telling me that malaria is #1 killer, but it kills the wrong people.
Yeah.
Tell me about that.
Yeah, malaria actually kills mostly children under 5 years.
So who should
and
it
pregnant.
kill then? Who are the right people
Pregnant.
to die?
oh my God, that is a $1 million question. There's no right person to die.
So what do you mean when you say it kills the wrong people?
Those are the most vulnerable people, and we need our mothers. We need our mothers. You know very well that without mothers in a family, you know, the ripple effects are quite enormous. And children can't live with their fathers alone. Let me not be an expert on that, but a lot of research has adduced evidence to that effect. So it is really killing the wrong people. We need the children. The children are our future. So we really need them to propagate our legacies. So when we say it's killing the wrong people, indeed it is killing the wrong people.
This thing seems convoluted, but then again, it should be an easy one. Because certain countries have eradicated it. We are failing to do that here. Why? Is it that sensitization is not done well enough? Is it because of our high illiteracy levels that people don't get it, that they should do certain things to try and avoid this? Because, you know, this should be easy to remedy, I would think, Dr. Opigo.
Yes, sure, and both of them. In the 60s and 70s, the world moved on malaria very seriously. They prioritized it. And over 40 countries eradicated it. In the 90s, in between there was complacence and the world relaxed. In the 90s, people said, wait a minute. This is the priority we need to deal with. And the concept of rollback malaria came, which was meant to actually put it back on agenda. And you can see the several initiatives which were born after that. The Global Fund, the President's Malaria Initiative. People designed better technologies to control malaria, better medicines. People like Bill Gates actually have said now that malaria is their priority. They want it eliminated in their lifetime. In Uganda, we have the malaria reduction strategic plan, which we hope by 2020 takes us to pre-elimination level.
What I'm trying to hear out from you is why are we failing? Is it that people are not getting the intervention mechanisms or measures, use mosquito nets and so on? What exactly is happening wrong?
One, of course, initially the technologies, the funding, the strategies were missing, but also the people's action, and that is why we are using this campaign to really get the people to take the action required to test, not to have self-medication, to complete treatment, to sleep under nets. Malaria is also a social problem. That's why me and you, who are of a certain social status, we don't get malaria because we have nets on our windows, we sleep in a net, we put repellents, but when we get it, we treat it very fast. So it doesn't give a chance for the mosquito to pick it from you to the next person. So we really need the community to do their part.
Dr. Ola, your district health officer in Woya district, and in our chief chat earlier on, you were telling me that Kampala is doing fairly well for the reasons you've adumbrated. You know, it has people that are fairly well off, and so they can manage this. How is Woya doing regarding malaria?
We currently have seen a slow drop in the cases that we noticed in the last 6 or so months, 6 to 9 months. But I think it's because of the dry season. We expect the cases to rise. We actually reached to around 11,000 cases in a month, though Noya is among not the very affected districts in the north. I think Gulu is the most affected, and Gulu would report about 10,000 cases in a day, in some of the days when we had the can I call it an epidemic? So that is how we are faring. And right now, we've recorded about 30 deaths, not as many as other districts, but I think it's also relative, it's proportional to the population in the district as well.
So what are people doing to tell these people to avoid this? How are you managing this? Because I'm told sometimes mosquito nets are given away, people use them for fishing, they use them as wedding gowns and the like. What are you doing on ground?
We have carried out a lot of behavioral change communication campaigns. We've done talk shows, we've done community dialogues in schools, in the communities as well. We've moved around with mobile vans, involving the community in drama shows, showing them the importance of actually using nets and how to maintain the nets as well. So that is as far as, and even trained VHTs, the village health teams, to provide health education, and they are also treating what we are calling the mass treatment of fever. They only treat people who present with fever, just because of the scale of the epidemic, just to help. At least that's the first stop for the people, because accessibility to services is quite low. So that is as far as we have done, and we are still continuing to do that, even providing mobile outreaches to the population. And we've urged the local leaders to come up with bylaws for people who misuse nets, and we've actually apprehended a number of people.
Dr. Opigo, there was a time when we were trying to do some indoor residue spraying, and then debate became rife about diphenyl trichloroethane, DDT. Yes, a mouthful of the word. How did that fall through our fingers? Because we thought, you know, we can get to do this, and some thought this DDT thing is not very good, and then others are saying, wait a minute, why should we use the controversial one? And there are others that are safe to use. We do the spraying and eliminate this thing once and for all.
Thank you, Joel. Actually, there are so many chemical groups. DDT is a controversial one, but we have other groups. We have been using benzocape, which is in a group we call carbamides. Right now, actually, we are switching to one called actelic, and the Prime Minister is going to launch it in later on Monday. Spraying the houses is a very effective way of controlling malaria, because the mosquitoes sit on the wall, they simply die. And the new chemical we are going to doesn't kill only on contact, it even fumigates the air. And then it helps also deal with the nuisance of mosquitoes, and even those which don't cause malaria, even nuisance of other crawling insects, including bed bugs. So, but apart from spraying, we need to do a number of other things. For mosquitoes, bed nets, larvicidin, which we are testing in Nakasongola, and then, but we need to also clear the human beings of the parasites, so that the mosquito has nothing to pick from me and take to you. No, Ugandans move around with a lot of diseases in their blood. We need to clear it out, especially one which can be treated. But most important now for us, is to prepare to detect early or predict epidemics and deal with them before they kill people in big numbers. We are now suffering from success. You know, when you get malaria down, it brings some vulnerabilities. What we're having in the north is actually a problem of success. We had 6 years of spraying and malaria was brought to less than 5%. Clinics almost closed. I used to work in an upcountry hospital and we used to get medicine from them because they no longer needed their medicine in the Gulu area. But unfortunately the community relaxed because they were no longer seeing mosquitoes. You know. Also the immunities go down, and that is what we fear about Kampala, Kabale. We are preparing to strengthen our surveillance and develop special programs. We are stratifying the country. These areas of low transmission, we have a special program for them, and we maintain as part of moving to pre-elimination levels. So the future is good. We need a lot of support. Uganda has eliminated many diseases. We don't see polio anymore. We don't see smallpox anymore. We don't see guinea worm. See, we don't see blasia. Measles no longer disturbs our people.
Leprosy.
Yes, leprosy, you don't see it. And the methods are
so we should be able to deal with this. Dr. Ola, some people have said that in districts like where you are, for example, in Woya, one of the reasons why people don't go to health facilities is because, one, of course, they are a distance apart, and then when they go there, they might not find the medication they need, they might not find the health practitioners there, the doctors and the like. And I've had some people also complain that when they go there, they're not well treated. This is impeding our fight against malaria, is it not?
That is if it is true, if all those allegations are true. But what I have seen is that the medicines, the drug supply is a little bit, it's improved. And we've tried our best. We have recruited staff, especially health center 3 level, because we don't have a health center 4. Recruitment was done for health center 3s and 4s. So the staff are there. Maybe the biggest impediment is accessibility. Like in my facility, in my district, we only have 19 facilities serving a population of 128,000. So accessibility is quite low. That is one of the biggest challenges that we have in my district. And that's why I think even the village health teams that we trained have been very helpful, because they can reach the people down there. The first stop center for the people with malaria, or can I say with fever.
Okay, so we hope that these good people at the ministry can get to remedy these issues. Thank you so much, doctors, for joining me. Let's keep up the fight.